The next session for today will be case-based discussions. To moderate this session, I would like the presence of Dr. Marlis on stage, Dr. Dinesh Jain.
Good morning, everybody. So, what a privilege to be here. So, my privilege now to introduce Dr. Dipanjan Chatterjee. He's the Director, ECMO and Transplant, Program Heart and Lung, Head of the Department of Cardiopulmonary and Critical Care in Kolkata, India. And we're looking forward to his case of antihypertensive poisoning on ECMO.
Secretary Chairpersons, dear delegates. It makes me nostalgic to speak on this topic because this was our first case of ECMO way back in 2014. And luckily the patient survived, and after that we had a good ECMO program going on. Uh, Whatever data I could retrieve from my old database, I have presented, but unfortunately, I know that it's not very complete, but I'll try to give a picture of the patient. So the calcium channel blockers are widely used as antihypertensives, and very commonly in India, they are available over the counter. More than 60% of the fatal incidents of cardiac drug overdose poisonings, they are caused by the calcium channel blockers because they are the most commonly used drugs for the antihypertensives, uh, and they are cheaper. So it inhibits the L-type calcium channels, and the commonly used amlodipine has peripheral vascular effects in the therapeutic doses, but in the supratherapeutic or in the poisoning doses, they have cardiac effects too. So these cause the cardiac toxicity as well as some non-cardiac toxicities also. Our patient, this was an 18-year-old girl who was admitted outside initially with restlessness, and she was developing hypotension and respiratory distress, and she was then referred to our institute. When she was transferred to our institute, on careful history taking, we found that the parents said she had ingested around 45 tablets of amlodipine 5 milligram and 25 tablets of diclofenac. So it was almost 15-16 hours over after the ingestion. The patient was immediately intubated in the ER. The patient's saturations were low. The patient was having profound hypotension with borderline urine output, and the echo showed fair biventricular function. Initial resuscitation consisted of IV fluids, noradrenaline, adrenaline, vasopressin, calcium gluconate, as well as glucagon and high dose insulin and dextrose. Glucagon at that time was not was still in use. Nowadays it has gone out of our recommendations. So the patient was oliguric, rising creatinine, and the patient was started on hemodialysis. The lung X-rays were worsening. The ventilator FiO2s went up to 100% with increasing of PEEP, and you can see the PO2 was only 45. Lactate had gone up to 7.5, but there was no, bicarbonate was normal. So at this time, we were referred to. The patient was initially admitted under the critical care medicine department, and then when the PO2s were not maintaining, we were referred to. The patient had a central line and a dialysis line in the neck. We planned a veno-venous ECMO because the patient was maintaining blood pressures with supports as well as the cardiac function was also maintained. We used a 24 French femoral drainage and 20 French IJV return cannula. The flow maintained was around 4 liters. The patient was around 80 kilo and 160 centimeter in height, and the vasopressor doses gradually started to come down. as well as the lactates. The ECMO run was only for around 8 days and 14 hours. Tracheostomy was done after the patient was decannulated. Remember, this was our first ECMO run. The patient was on heparin, and at that time we were novices in ECMO, so we were a little bit reluctant to do a tracheo on ECMO. So once the patient was off ECMO but still on ventilation, we did a tracheostomy, and gradually the lungs improved further. Ventilation was weaned off. Renal functions improved. The hemodialysis was stopped, and the patient was discharged home after 5 days of trachea-decannulation. Though most literature suggests VA ECMO, still VA ECMO is the recommended mode for calcium channel blocker poisonings, because these patients would be in shock, and they will be in metabolic acidosis with end organ dysfunctions. Still, our patients, we got the patient a little bit late, was though hypotensive initially, but it was managed by our vasopressors, and the patient had a good ventricular function. That's why we chose for a VV ECMO. The patient, the cause of ARDS may be a non-cardiogenic pulmonary edema, maybe some component of cardiac function would also be there, but it is mainly non-cardiogenic pulmonary edema that is postulated as ARDS in this patient. Thank you.
Thank you for a very good talk. So we all manage overdoses, so we all learn from you. Thank you.
Good morning, everybody. We are going to discuss case of difficult airways and ECMO. The speaker is Dr. Vinod K. Singh, is MD, EDIC, FRCP, Senior Consultant, Institute of CCM, Shri Gangaram Hospital, New Delhi. His area of interest is ARDS and ECMO. He has special achievements. He is the past president of ESOI, past chairman of ISCCM, New Delhi, fellow of ISCCM, and fellow of ACCP. You are welcome here, Dr. Vinod K. Singh.
And thank you, Chairperson, for inviting me. And thanks to organizing committee member. What I'm going to talk about, the airway management. Where is the role of ECMO? Before going to that, we all know that if you face a difficult airway, it is challenging for the intensivist. And not only challenging for the intensivist, it is devastating for the patient also. If you fail to put an airway in such patients, the mortality is 100%. And we all know that ECMO is the way when all conventional treatment fails, whatever the ARDS, VA or VV ECMO. So how we can combine new indications for the ECMO in such situation, and in my case, I'm going to discuss that. So outline is the concept of ECLS in airway problems, the case discussions and indications, what are the evidences, and what are the practical consideration when we are trying to prepare in such cases. So the ECMO can provide airway support where the conventional airway management has failed and facilitate precise dissection and reconstruction of the tracheas, and also is a hemodynamic stabilizes the patient. ECLS requires for the short duration in this particular type of indications, and bleeding can be minimized with precise and effective control of the ACT. So I'm going to discuss a case. This is a case of 48-year-old gentleman was brought to the SGRX of Gangaram Hospital Emergency Department with severe respiratory distress. The patient has a heart rate of 160, the blood pressure 144/66, tachypnea, and the saturation is 86% on high flow oxygen. The patient was reaching, the patient has a stridor, and he had a massive neck swelling with the stiffness of the neck with limited mobility of the neck and just 2-finger opening of the mouth. He was managed in the emergency with a non-invasive mask ventilation and shifted to the ICU with a very severe respiratory distress. If you look at the background history of the patient has undergone a radical surgery followed by a local radiotherapy for squamous cell carcinoma of the buccal mucosa in 2012, and had a recurrence of in June 2015. He underwent a radiotherapy and right command resection again, and also he was done a tracheostomy. He was decannulated 1 month later. After that, he went home. 5 months later, the PET CT was done, which reveals the recurrence of the disease for which he was started on the palliative chemotherapy. The post-3 cycle of chemotherapy started having difficulty in breathing. The CT scan of the neck revealed a tracheal obstruction due to the tumor recurrence at the tracheostrum site, and the vertical length of the tumor was almost around 2 centimeter over the, and 90% lumen was compromised. This was done in some other hospital from which the patient was shifted to us. If you look at the CT scan, you can find that how the complex obstruction was that there are two sites of obstruction, upper airway and the tracheostrum site, and both were causing the patient's problem. And he was in quite distress also. Almost 90% blockage of the lumen you can see here in the CT scan transverse section. So the patient came to the ICU, the team of intensivists, pulmo people, CTVS examined in the casualty also, the elective endotracheal intubation, cricothyrotomy or a cervical tracheostomy are not possible in this patient. The mediastinal tracheostomy needed, but general anesthesia, no anesthetician out of hospital agreed to give anesthesia. These people, they are in afraid that the patient might asphyxiate. A rigid bronchoscopy was not an option in here because there was no mouth opening. It was not possible to do a rigid bronchoscopy and ventilate the patient. A fiber optic bronchoscopy was one possibility, but the pulmo people were not ready to do fiber optic because they were afraid that the patient might completely obstruct the trachea and the patient will die due to asphyxia. This is the situation we faced when we took this challenge. So this was a difficult airway we can call it an impossible airway because no way the conventional treatment is going to support this patient. And severe respiratory distress, the conscious patient was, the family was ready to do everything which is required to be done. So what to do if you do not intervene in such patients? There is outcome, and which is asphyxia and death. The alternative mode of gas section, we thought, okay, we'll take this challenge and put the patient on ECMO. And we have two challenges, the anticoagulation and cannulation, because the patient was not on ventilator, there's no way we could have sedated the patient. So what we did a bedside bifemoral venovenous cannulation was done, and right femoral 23 French with left femoral 20 French cannula was done. We took this because we knew that there's no benefit of putting a larger cannula. Patient is on a spontaneous respiration. So we are expecting a flow of not more than 2 to 2.5 liter in such patient in spontaneous breathing patient. And also we gave some 5,000 unit of unfractionated heparin. We achieved oxygen saturation of 98%. Initially it was flow rate of 3 liter per minute, FiO2 of 1 on the ECMO side, and gas flow was kept at 3 liter per minute. Once the ECMO flow was established, the patient was deeply sedated with an intravenous of fentanyl and midazolam was given. Look here, the patient was put on a non-invasive ventilation and the cannulation was done, and by whom with the 25 and 20 French cannula was done. We are successfully in cannulating this patient, conscious patient without sedation and without any paralysis, even without ventilating the patient. Now the problem started again. After initiating the ECMO, the bronchoscopy was done via the nasal route, and oropharyngeal vocal cord anatomy was completely distorted as was expected before putting the patient in ECMO. The tumor was visualized 2 centimeters from the vocal cord, almost completely occluding the tracheal lumen. The access of bronchoscope was due to the convoluted pathway, it was not possible and was very, very difficult due to distorted anatomy. So it was not possible to reopen the trachea at this stage. So the pulmo people stopped doing the bronchoscopy and they told us, okay, take the other mode and go for tracheostomy again. Meanwhile, the patient will have an episode of hypotension also. The during procedure, despite the ECMO support, they started desaturating because of the very high respiratory rate and high cardiac output. The patient started desaturating. So the ECMO flow has increased slightly. We put the patient in inotropic support as the bronchoscopic development was not succeeded. So we made a last attempt to do the tracheostomy at the previous site of tracheostomy. At this stage, the patient was paralyzed. So we put the patient on neuromuscular blockade agent, and our surgeon started doing tracheostomy, and incision was given below the previous tracheostomy site. The trachea below previously site was pulled up, and a 7 size tube was passed, and the piece it was we were succeeded in passing the tracheostomy at the same tracheostomy site. The ECMO support was removed after 1 hour and the inotrope and ventilator weaned off over the next 4 hours. Probably this was the shortest ECMO. We after 1.5 hours removed the ECMO support. The patient was was on spontaneous breathing with oxygen by the T-piece and comfortable respiratory at 20 per minute. And he was continued with now intervenous antibiotic. 1 week later, he was discharged in comfortable condition for the chemotherapy. So this is how we done. This is a very rare case, and we have not found any literature of such type of ECMO support in India. So the total tracheal obstruction is a challenging situation, and the physician, even the experienced anesthetic and the thoracic surgeon is not in a condition to do this. In our case, it was not possible to establish the definitive airway without causing a severe hypoxia and patient facing imminent respiratory arrest. So what are those situations, airway situations, where you can think for ECMO? So the ECMO airway support is considered if you have a failed airway and the surgical airway is not possible. This is one situation where you consider VV ECMO. Second, we can consider that the patient has got an acute airway obstruction. The obstruction is complex and the conventional method is not working, where you can think for a VV ECMO. The third is routinely, not routinely, but some situations is done that airway surgery. But here, we try to put the patient on ECMO, those patients who are high risk for intubation, difficult intubation, put the patient on ECMO, and then you can go for either endoscopic surgery or even the major surgery. So the complex central airway disorder, life-threatening airway compromise, unexpected total tracheal obstruction, tracheal surgery, tracheobronchial plastic procedure, and difficulty airway. Honolulu has actually, there's no any study, but the case series and the case reports, and based on that, these are some of the indications where the conventional method has failed, and you can try a patient to put an ECMO in cases of difficulty airway. So, who are the patients? Potentially correctable disease. The correction is not feasible due to the trickle hypoxemia, and there is a failed ventilation or the cardiac failure, where we can think the patient should go for ECMO. So the application of ECMO for management of life-threatening airway obstruction has been limited, and the first report of ECMO in the management of acute tracheal obstruction was Higashi et al. 1989. Since then, there have been more case reports, and a recent case of series of 19 patients by Hong, who has studied the ECMO for managing central airway obstruction. There have been no case reported in ECMO in this indication in India, even in the world, that the patient who has got a difficult airway and putting a conscious patient cannulating and doing the tracheostomy in such situations. What is the practical consideration? We all know that the VV-ECMO configuration is very important, and awake cannulation we have to do. If the patient is unable to lie down, and intubation due to dyspnea, risk of high respiratory arrest, and indication for we should go for a FEM configuration is the best option, because we are doing a lot of procedures in the neck, so we don't go for femoral or jugular. FEM configuration should even no for the dual lumen, because a lot of things has to be done in the neck area. So FEM is the best. A central VA cannulation, very difficult in such situation. So approach should be a single site cannulation using bicabal dual lumen catheter. Okay, that can be done, but there are a lot of chances of changing the catheter site and recirculation and changing the position of the catheter. So the best way to do is that the dual site cannulation, and the best way is femoral rather than going for femoral cannulation. Now, airway and ventilation initiated under local anesthesia can be performed, and once the ACL is initiated, patient can be sedated, patient can be paralyzed, and even patient can be taken to the minor or interventional surgery. Anticoagulation, as we in our case, we did that. There's no need to go for a continuous anticoagulation, because all the circuits who is presently present can run even without anticoagulation for some time. And in airway, when you are trying to do a surgery, trying to do a procedure, whether there is a high risk of bleeding, no need to give anticoagulation to such patients. Although the flow rate remains low, but patient can be managed without anticoagulation. Weaning and discontinuation are not going to talk, but it is very short ECMO. And these are the some of the report. The 7 patients received ECMO to the facilitate respiratory and promote stability during tracheal surgery. This is the second I discussed that the people have used in the case series in such patients, and they have found this is the useful technique or useful life support treatment when all the conventional measures are not going to act for your patient. So, in my conclusion, a key reason for limited use of ECMO in acute life-threatening airway obstruction is that the time is required for the initiation, because most of the time you will not find sufficient time to initiate the ECMO. Patient will either asphyxiate or the patient will hypoxemic and going to have death. Today, the ECMO is safe and effective available method for oxygenation in case of life-threatening acute airway obstruction, where the conventional method of airway access are not immediately possible without completely jeopardizing the airway. This is very important fact. And that's why many difficult airway association has kept the ECMO as one of the options for managing such patients. Thank you for your listening.
Thank you, Dr. Vinod, for a nice case. We are the first case in India. So it's very good, you see, modality and where you can't do anything. Question answer session later. Thank you, Dr. Vinod. Once again, we will have a question answer session later on.
Good morning, friends. As we know, the horizon of ECMO is increasing day by day. So we have another indication to discuss today where ECMO has a good role to play, and we have a prominent speaker with us. So along with my co-chairpersons, I would like to invite Dr. Sanjeev Mittal, who is a consultant critical care specialist from Sir Gangaram Hospital, Delhi. Again, the area of interest, ECMO Center coordinator for the hospital. Lot of publication and conferences organized by Dr. Mittal. So over to you, sir.
Thank you, sir. Good morning. Tropical diseases are diseases that are prevalent in or are unique to tropical and subtropical regions. The colder climate in the western countries forces vector hibernation. These diseases became of interest to the Western world first in the era of colonial settlers when they encountered malaria, to the present area of globalization when the returning traveler has become the focus. It is estimated that 8 to 15% of all returning travelers are ill enough to seek medical attention on their return, and the commonest symptom is fever. It's not only about the climate, the vector control, it's also about the practices that are followed in the tropical region, use of pesticides and certain poisons, as we are all aware of. So for ECMO practitioners in the tropical region, is it an opportunity to work more, learn more, or is it also a responsibility, as in one of the articles Dr. Pavoni had written, to educate the world? So these diseases were earlier called neglected tropical diseases. WHO still lists 20 of them, including malaria and dengue. That is mainly administrative and financial reasons. But we cannot afford to neglect them anymore, with 40% of the world's population living in the tropics. And these neglected diseases are no more confined to the tropics. This map here shows the blue shades. Even in US, 3 neglected tropical diseases, the so-called ones, are reported now. So what's so unique about tropical diseases? They have varied presentations. They are syndromic, varied severities. The outbreaks affects all age groups. There is rapid deterioration in severe forms of the disease, and the management of reversible phase leads to good recovery. Broadly, when we club them together, they give us 4 indications. The ARDS, bacterial, rickettsia typhus, you can recall, viral, you're all aware, parasites, malaria. Myocarditis, dengue, we'll be seeing a case of dengue myocarditis. Septicemia, we've had a very good talk. And poisonings, aluminum phosphide is the commonest that all of us ECMO practitioners are in a way proud of. Looking at the list of diseases, the tropical diseases, you will find rickettsia, severe malaria, dengue here, H1N1, which is very common now. Leptospirosis, there have been case reports of managing acute respiratory failure in cases of pulmonary hemorrhages in leptospirosis. So we'll go with some case reports published. The author here has taken 3 cases of returning travelers, and he calls it imported malaria. First case was a 53 years old male. He was a diabetic and CAD case. Did not take any chemoprophylaxis while he was in Angola. He presented with fever, chills, myalgias, and headache. Examination, there was nothing significant, and the blood smear showed falciparum 2% parasitemia. Platelet count was 18,000. In the hospital, he was given IV quinine and doxycycline. On day 3, he progressed to hypoxemic failure. He was put on a ventilator, and the usual drill was followed. Blood cultures were negative, echo was normal, and CT thorax done was in line with ARDS. On the ventilator, there was persistent hypercapnia, hemodynamic instability, so VV ECMO was initiated on day 7 of the ventilator. However, he had multiple episodes of infection. He got out of one, had another, and did not survive. Case 2 was a 39 years old male, hypertensive, again no chemoprophylaxis, presented with same complaints except he also had vomitings. On examination, he was febrile and somnolent. Blood smear showed falciparum, 3% parasitemia. Platelet count was 80,000. He was also given quinine and clindamycin. On day 6, he progressed to hypoxemic failure. He was put on a ventilator. Blood cultures were negative, bronchial lavage was negative, CT thorax and everything suggested a full-blown ARDS. He did not have any bleeding episode. VV ECMO was initiated and he was weaned off ECMO in 7 days and we liberated from ventilator after another 7 days. Case 3 was a 46 years old American woman. She returned from Uganda. She was adherent to chemoprophylaxis during her stay in Uganda. She had 2 weeks history of fever, night sweats and myalgia. When she came back, she was treated empirically for resistant falciparum malaria as an outpatient. However, she developed vomiting and dehydration. On examination vitals, she was tachycardic, chest x-ray was normal. Blood smear showed P. vivax and OA. Parasitemia was only 0.5%. Platelet counts were adequate. The treatment in the hospital was changed to chloroquine. On day 4, she developed dyspnea and lung infiltrates came up. She was put on a ventilator and she was shifted to University Hospital because the ECMO facility was not available here. VV ECMO was initiated almost immediately. Blood cultures were negative. She was started on IV quinidine and doxycycline. ECMO decannulation was done on day 10 of ECMO and she was liberated from ventilator 7 days later. She had episodes of ECMO cannula migration. She had multiple bleeding episodes and multiple transfusions were given. In this case, the ECMO physician used the strategy of using low level of anticoagulation. ARDS can occur in malaria alone or with multi-organ involvement. It can occur in early or in late phase. It is estimated that 5 to 25% of all falciparum parasitic cases and 1 to 10% of VIVX cases develop ARDS. Pathogenesis of ARDS in malaria is not fully understood. Parasite sequestration and upregulation of pro-inflammatory cytokines, which persists even after parasite clearance, could be the common cause in falciparum. However, in VIVX, since there is not significant parasitic sequestration, this could not be the cause. ECMO is a suitable salvage therapy when lung protection ventilator strategies result in unacceptable levels of hypercapnia and acidemia. This hypercapnia has another angle to it because it can potentially worsen cerebral malaria by causing cerebral vasodilatation and increasing the ICP. There has been some experience. I have come across a paper where extracorporeal CO2 removal was also done in one of these cases. Patients with severe malaria are also highly susceptible to bacterial infections, and since this is a major fear of an ECMO physician, we are worried on that count. Risk of DIC, hemolysis, and thrombocytopenia because of the disease process is further aggravated. So ECMO is not without risks even in these cases. However, it is a useful therapy even in the presence of risk of bleeding when ARDS is refractory to conservative treatment. Let's come to the second broad indication of tropical diseases, and that's myocarditis. The author here has presented a series of 4 cases. They all came in cardiogenic shock. They were not diagnosed dengue, and only the etiological search found them as dengue serotype 2 positive. The author feels that dengue in myocarditis is underdiagnosed. So I'll be just telling you about one case. They all had similar presentations. This was a 47-year-old female. She presented in the casualty with cardiogenic shock with LV ejection fraction of 10%. She had a rapid deterioration phase. VA ECMO was initiated. She was put on a ventilator along with IAPP. Coronary angiography was normal. She required LV decompression. The peripheral ECMO was converted to central ECMO and she had massive hemorrhage. She went into shock. However, she evolved favorably. Etiological search later found dengue serotype 2 positive. Cardiac MRI done 24 days later, still had evidence of myocarditis. Dengue has a wide range of presentation. 1 to 2% of all dengue patients are presented as severe dengue, either as dengue hemorrhagic fever or as dengue shock syndrome. ARDS is seen relatively less, only in 1.8% of severe dengue. However, myocarditis is more common, estimated to be 12 to 40%. Diagnosis of fulminant myocarditis should be considered when a patient suspected for dengue presents with congestive symptoms. Pathophysiology of cardiac involvement is not clear, could be direct viral invasion or immunoinflammatory response. Management is challenging due to plasma leakage and hemorrhagic conditions. VA ECMO is possible and is a strong contender for managing refractory cardiogenic shock. Long-term prognosis is excellent, and there is a similarity between chikungunya and dengue. So, what about risks of bleeding? Now, we all know we'll have a session also later in this day on bleeding. Also recommends use of anticoagulants. One, we are very clear about it. Second, platelets are indispensable for any clot formation. Agreed. So there is a study, there's a review rather of 34 studies which had 201 patients. The median duration of ECMO was 4.75 days and it had VA and VV ECMO. And this was a review where no anticoagulation was used at all during the entire ECMO. The authors found that there was 22% incidence of thrombotic events and 32% incidence of bleeding events. One person even had intracerebral hemorrhage. And the authors attributed this to the better technology, the phosphoryl choline coating of the circuits, and the advancement. However, ELSO does not recommend not using anticoagulants so far. The strategies that ECMO we would recommend, or I would rather say are possible, are accepting a lower level of anticoagulation and having prolonged periods of not using an anticoagulation if the risk reward benefit suggests using ECMO in these patients. So, what all other diseases can cause myocarditis? All these diseases and myocarditis and tropical diseases can present as heart failure, cardiogenic shock, ventricular arrhythmias, and sudden cardiac death. So, this is another etiology of myocarditis. All these blue ones, we'll find a lot of tropical diseases here. Coming to another kind of tropical problem, and this is a paper that has been published by our host here. They have reviewed 83 cases where they did VA ECMO of aluminium phosphide poisoning. Now, aluminium phosphide poisoning, we all know, is a poison that is used in the wheat growing areas. And a lot of work has been done by the faculty here and in some centers in other places also. Aluminum phosphide, we all know, causes severe myocardial depression as well as ARDS. Patients present with myocardial dysfunction, severe metabolic acidosis, and refractory cardiogenic shock. There is no specific antidote for phosphine gas. Half-life of phosphine gas is short, 5 to 24 hours. And this poisoning I remember from my housemanship days. They used to say that if a patient survives, that means he did not consume the poison or you misdiagnosed the patient. Then came the use of magnesium therapy. There was a study in Meerut Medical College, and I also remember using magnesium in higher dosages in one patient, and the patient survived. And when we were busy celebrating the success, we discovered that all the phosphine gas that was supposed to be released in the body actually was released in his cup of whiskey outside while he was writing a love letter to his girlfriend. Good news, myocardial damage and ARDS is reversible. Timely initiation of VA ECMO is a promising modality, and this study has demonstrated there is a significant benefit. Mortality was only 33%, and now, because of similar studies and success with these patients, a VA ECMO comes to your mind as soon as you see a patient of aluminum phosphide poisoning in casualty. So, are we hesitating to use ECMO in a lot of indications in tropical diseases? And if yes, why is it? Because there is lack of conclusive evidence. We can understand why there is lack of conclusive evidence, but we should not confuse it with lack of efficacy. ECMO therapy is not without risks. It's expensive. Expansion is a relative word. We shoulder the responsibility of doing more and guiding more. Thank you.
We all would like to thank and congratulate all our three speakers, Dr. Chatterjee, Dr. Singh, and Dr. Mittal, for their wonderful and thought-provoking case-based discussions. Case-based discussions are one of the most interesting medical learning tools, and I do hope we will have some questions in the audience. So we are open to any questions for the speakers. I think we have a question here. Getting a mic for you.
Thank you. There we go. So thank you for the wonderful presentations. For Dr. Mittal specifically, one of you bring up the good point that many of these tropical diseases are fairly rarely seen outside of this region. With that being said, I work in Atlanta, Georgia. I see malaria on a monthly basis, all imported into the U.S. One of the places where you all can really help is I'm lucky to have infectious disease physicians there that have a lot of head knowledge. They don't have a lot of practical knowledge in what are the things at the bedside that make these patients better. I would love to see yourself and a group of folks from tropical disease experts put together a way, a phone number, a WhatsApp, a something, so that when those of us who are practicing in the rest of the world come up against these diseases, that we have someone to reach out to and that you can teach us from and do. So just less of a question and more about something to think about how you can help the rest of the world.
So nice of you to say that. In fact, when I was preparing for this talk, I came across an article by our Dr. Pavoni, and he has been a teacher in many ways. So I was also wondering that are we really using, at least thinking of ECMO less in tropical diseases? And I thought what we have done to aluminum phosphide poisoning, probably we should work on similar lines in other indications also. Thank you.
just like to share what we did to a chikungunya patient. This is in 2017, when chikungunya between the months of July to September was very rampant in Delhi around that area. And we were losing patients because of renal dysfunction. And I had a very close relative who was septicemic on chikungunya going into AKI, and he was on a CRRT machine. And when you put in a CRRT, you automatically think of ECMO. So we put him on a hemadsorption cytosorb in our ICU. The renal function improved, but the heart sat down. And that's when we started, and the PCO2 and the started to build up, and the PO2 came down. That's when I went from the cardiac center and I said, we'll put a low flow ECMO, VA ECMO on this patient. We put in a peripheral VA ECMO. We didn't put the distal ischemia link. For 2 days, there was some ischemia. On the third day, we put in a 7 French catheter there. And to our surprise, on the 18th day, the patient was sitting up. So, a gamut of so many things and a hesitancy, as Dr. Mittal rightly pointed out. Why would you use a VA ECMO or a CRRT in a chikungunya patient? You don't think of it because there are expenses involved. We do think of cost effectiveness of a therapy in a place like a tertiary center, even like AIMS. But because you have the knowledge and you have the people with whom you can discuss, it makes it easier. And I think this is a very thought provoking indication, all three of them. When it's an impossible airway, when it's a poisoning beyond 45 tablets of amlodipine is a disaster if overlooked not in time, or something like this, like dengue, chikungunya, which come on in spurts in India. The moment it's humid, it is a very bad epidemic that comes on. August to September are bad months. We all have faced it many times. So I think it's a good indication. Thank you to all the speakers. All three did well.
Thank you, ma'am. Thank you for your very informative comments. Any other questions in the hall? Have you got a couple of people? We have time.
In our area, I thought this would be an ideal topic to touch and develop upon. Thank you.
Thank you. I'm sure the speakers will be around and if there are any more questions. Okay, we'll take one question. He's very keen.
Yes, thank you so much, sir. So regarding the tropical illnesses which we talk about, so usually these patients like malaria and dengue, all the patients are most of these patients are thrombocytopenic and have liver dysfunction too. Sir, I just want to know that you told that very much there is hesitancy putting this patient on ECMO. So can we have some 2 or 3 points that we should not hesitate in putting this patient on ECMO because most of these patients have liver failure and they do have thrombocytopenia as well. So what are the points? I just want for 2 or 3 points when we should go for ECMO and when we should not.
That's actually a very difficult question to answer. However, we have certain strategies. So that's difficult because it is a scary situation, no doubt. How I would go ahead in such a situation is probably accept a lower level of anticoagulation. I would use anticoagulation because bleeding happens due to so many other reasons in ECMO also. And the second thing that we can also practice a period of not using ECMO. Dr. Oli has just now said that these are going to be short ECMOs. And I also think that the usage of modern circuits helps us in using lesser amount of anticoagulant. Would you like to add
Sorry.
anything?
Thrombocytopenia is not unique for this condition. In majority of our do come across thrombocytopenia more so in India. When there is sepsis, we will have thrombocytopenia. So we tend to keep like 40,000 as an empirical number, below which, above which we tolerate with that. Even with the hepatic dysfunction as well. Some of these organ dysfunctions do happen when the blood supply to them or the hypoxia is suffered by those organs. So once you support them and get rid of this hypoxia, then they might start to recover as well. As you know very well, liver has got a very good regenerative capacity too. So it is proper organ support which we can provide during this period. Without that, they are going to demise.
Thank you, respected moderators and speakers. It was a highly enlightening session to listen to some real-time experiences and their management. Thank you, everybody.